If I asked you to name, like, the absolute most common medical complication of childbirth, your mind probably jumps straight to the physical stuff.
Oh, absolutely. I mean, most people immediately think of gestational diabetes or maybe preeclampsia.
Right, or severe hemorrhage, something like that.
Mm.
But you'd actually be wrong. The most frequent complication isn't strictly physical in that traditional sense, though, its roots are deeply physiological.
Very deeply, yeah.
It's postpartum depression. And it affects 1 in 7 new mothers. 1 in 7.
It is a staggering metric when you frame it that way.
It really is. I mean, that
Yeah.
makes it measurably more prevalent than gestational diabetes.
Which is wild because we spend immense resources monitoring, maternal blood sugar and blood pressure. Yet the most statistically probable complication one that literally alters brain chemistry is often just treated as a secondary concern.
Yeah.
The cultural and clinical understanding of this condition is still just remarkably fractured.
Which is our mission for this deep dive.
Yeah.
Today, we are dismantling pretty much everything you think you know about depression after birth. We're going to look at the surprisingly complex biology, this huge paradigm-shifting cultural clash that altered modern medicine, and a demographic twist that forces us to question who actually gets this condition.
It's a lot to cover, but it's so important.
Okay, let's unpack this, because the very first concept from our sources completely upends the core definition of the illness. Like, the psychiatric community actually abandoned the term postpartum entirely for official diagnoses.
They did, yeah. Back in 2013, the architects of the DSM-5, that's the Diagnostic Manual for Mental Disorders, they updated the official specifier.
Right.
They changed it from postpartum onset to peripartum onset. And that shift to peri, meaning around the time of birth, it reflects decades of clinical observation that finally forced a change in the rulebook.
Because the data shows that, roughly 50% of these depressive episodes actually begin while the mother is still pregnant.
Precisely, 50%. So it fundamentally changes the threat matrix. I mean, if you treat this strictly as a birth-triggered illness, you're missing half the cases right out of the gate.
Wow, half of them.
Yeah. It is a pregnancy and birth-spanning mood disorder. So by shifting the name, the medical system is effectively mandated to begin screening for these symptoms months before the patient ever even reaches the delivery room.
And this is what's so weird to me. Looking at the diagnostic criteria, there is still this glaring, almost absurd contradiction.
Oh, the 4-week window.
Yes. The DSM dictates that to get this specific peripartum diagnosis, the depression has to kick in during pregnancy or within 4 weeks following delivery. Just a 4-week window.
Right.
Yet the World Health Organization, and like virtually all major epidemiological studies, stretch that danger zone out to 12 months.
Yeah, it really highlights that classic friction between diagnostic manuals, which, need rigid parameters for clinical trials and insurance coding, and the actual messy reality of patient care.
It's like a car warranty that aggressively expires after 30 days, even though the engine block is known to just spontaneously crack at month 9. I mean, if a mother presents with severe, debilitating depression 9 months after giving birth, wouldn't every doctor still call that a postpartum issue?
Any competent clinician would, yes.
Right.
But that 4-week constraint, it isn't just bureaucratic stubbornness. It actually reflects a genuine, ongoing scientific debate.
Oh, so?
Well, researchers are arguing over whether postpartum depression is a completely distinct biological entity with a highly specific trigger, which would justify a tight, immediate window, or if it's simply a standard major depressive disorder that opportunistically strikes during the most socially, physically, and hormonally turbulent year of a person's life.
Ah, okay. That makes the distinction incredibly important. And to navigate that debate, we really have to clarify what we're talking about, because the terminology gets thrown around so carelessly.
Constantly.
Let's start with the most common mix-up. Postpartum depression is not the baby blues.
No, and the conflation of those two is actively harmful. Look, the baby blues is a nearly universal phenomenon. It affects up to 80% of new mothers.
80%, that's almost everyone.
Exactly. It manifests as sudden tearfulness, mood lability, generalized anxiety. But the defining characteristic is the trajectory. It peaks around days 3 to 5 and resolves entirely on its own within 2 weeks.
Without treatment.
Right, requiring no pharmacological or therapeutic intervention at all. It is just a brief, self-limiting neurological adjustment period.
Whereas postpartum depression persists. It deepens, and it actively dismantles a person's executive function and their ability to care for themselves or their child.
Exactly.
Now, on the opposite end of the spectrum, PPD is also not postpartum psychosis. And this is a boundary that the general public often blurs. which has had just disastrous consequences for the stigma around maternal mental health.
We really have to delineate this clearly. Postpartum psychosis is a categorically distinct psychiatric emergency. It is exceedingly rare.
Like how rare?
It affects roughly 1 to 2 out of every 1,000 births. The clinical presentation involves severe hallucinations, delusions, profound cognitive disorganization, and a statistically significant risk of both suicide and infanticide.
Wow.
Yeah, it is not just a severe progression of PPD. The underlying pathology is completely different.
And the distinction between the two is exactly what got obliterated in the public consciousness, mostly because of the Andrea Yates tragedy in 2001.
Yes.
For those who don't remember, Yates was the Texas mother who drowned her 5 children, and she had suffered from increasingly severe, unaddressed postpartum psychosis across multiple pregnancies.
And what's fascinating here is how that single horrific event shaped the legal and cultural framework of maternal mental illness for an entire generation.
It was everywhere on the news.
Oh, absolutely.
Uh-huh.
The resulting trial, where she was initially convicted of capital murder before eventually being found not guilty by reason of insanity, it became this massive national flashpoint. It violently exposed the total inadequacy of psychiatric screening protocols.
And the justice system's total inability to process childbirth-related psychiatric emergencies.
Right. But the collateral damage of that media circus was just immense. It inextricably linked the concept of postpartum mental illness with extreme lethal danger to children in the minds of the general public.
Which built this massive wall of stigma. I mean, parents experiencing standard non-psychotic PPD became utterly terrified to disclose their symptoms. They feared that if they admitted to, like, profound sadness or overwhelming anxiety, it would instantly trigger Child Protective Services.
Because they assumed they'd be viewed through the lens of the Yates case.
Exactly. So if we strip away the extreme outlier of psychosis and the benign nature of the baby blues, what is actually driving standard PPD? Because the biology is fascinating, and people have been trying to decode it for centuries. I saw in the sources that Hippocrates actually documented cases of puerperal fever with mental disturbances back in the 4th century BCE.
Yeah, the historical timeline is remarkable, but the real inflection point arrives with a French physician in 1858, Louis-Victor Marseille. He is widely considered the founding father of perinatal psychiatry. He published this comprehensive treatise systematically linking mental illness to the physiological processes of childbirth.
Wait, in 1858, we're talking about the Victorian era, right? A time when women's health issues were routinely just dismissed as hysteria or, like, spiritual failings.
Exactly. For a physician to step forward then and argue that there is a measurable physiological trigger for this condition, it was incredibly radical.
The huge paradigm shift.
It was vital. Marseille laid the philosophical groundwork for the modern biological theory, which was eventually formalized much later in the late 20th century by British physician Katharina Jolton.
She championed the hormone withdrawal theory, right?
Yes, she aggressively pushed that theory, providing a mechanical explanation for what Marseille had observed a century earlier.
Let's trace that mechanism for the listener, because the endocrine crash involved here is just violently abrupt. Throughout gestation, the body sustains these historically high levels of estrogen and progesterone.
Massive levels.
But then, within 24 to 48 hours following the delivery of the placenta, those hormone levels, along with this crucial neurosteroid called allopregnanolone, they just plummet.
They drop off a cliff.
Right, from these massive sustained peaks down to near pre-pregnancy baselines, essentially overnight.
It represents one of the most rapid, extreme endocrine shifts the human body can endure without entering critical failure.
It's like a building's internal climate control being set to a blistering 100 degrees for 9 uninterrupted months, and then someone just rips the thermostat off the wall, dropping the temperature to absolute zero in an hour. Like, the idea that the brain's delicate neurochemistry can just seamlessly absorb that kind of shock is totally illogical.
And that specific neurosteroid you mentioned, allopregnanolone, that is the key variable here.
How so?
Well, it's a metabolite of progesterone, and its primary function is modulating GABA-A receptors in the brain.
Okay, for those who aren't neurobiologists.
Right, sorry. For those familiar with neuropharmacology, that is the exact same inhibitory pathway targeted by benzodiazepines, like Valium or Xanax.
Oh, wow. Yeah, it promotes calmness, it regulates anxiety, and it stabilizes mood.
So as progesterone crashes, the brain's internal supply of this natural anti-anxiety compound vanishes alongside it. The neurological safety net is just pulled completely out from under you.
That is the mechanical reality. And this hormone withdrawal hypothesis wasn't just, a compelling theoretical model. It actually provided the map to the very first highly targeted pharmacological treatments.
Because it proved its validity in the lab, which led to the FDA approval of brexanolone in 2019 under the brand name Zulresso, right?
Yes. Brexanolone is essentially a synthetic exogenous formulation of that missing neurosteroid allopregnanolone. However, and this is a big however,
Yeah.
the delivery mechanism underscored just how serious the biological deficit actually is.
Right, you couldn't just pop a pill.
No, it required a continuous 60-hour intravenous infusion in a closely monitored clinical setting. A 2.5-day continuous IV drip just to stabilize the brain's receptors. That alone illustrates the severity of the biochemical crash. You don't hook someone to a 60-hour IV for minor mood fluctuation.
You certainly don't. And the clinical logistics for that were understandably prohibitive for many. You had to have a hospital stay, and there was a risk of sudden loss of consciousness.
Oh, wow.
Yeah. Fortunately, pharmaceutical development iterated quickly. In August 2023, the FDA approved zuranolone, which is the first oral pill for PPD.
Oh, that's huge.
It is. It targets the same GABA receptor pathway, but it only requires a 14-day outpatient course. And the fact that restoring this specific neurosteroid pathway rapidly alleviates severe depressive symptoms, it's arguably the most robust evidence we have that PPD is driven by a profound biological mechanism.
But having the biomedical validation and an FDA-approved drug, that's a massive victory, sure, but it only solves half the equation. I mean, a medical intervention is totally useless if the cultural environment actively discourages patients from using it. Which brings us to a frankly surreal moment in pop culture that fundamentally altered the trajectory of public health.
You're referring to the events of 2005.
I am. Brooke Shields publishes her memoir, Down Came the Rain. And in it, she completely strips away the glossy veneer of celebrity motherhood. She is painfully candid about her battle with severe PPD, her initial reluctance to seek help, passive thoughts of self-harm, and ultimately how antidepressants and therapy literally saved her life.
It was a massive cultural moment. Releasing a book with that level of vulnerability was a profound professional risk for an A-list actress at the time. The cultural default was still very much to view postpartum struggles as a personal defect.
And then Tom Cruise goes on national television and just aggressively attacks her for it.
Yeah.
He publicly criticizes her reliance on psychiatric medication. He labels psychiatry as pseudoscience and insists her condition should have been managed with, like, vitamins and exercise.
The incident is often remembered as just this bizarre celebrity spectacle, but you really have to analyze why his narrative found an audience at all back then.
Right, why did people listen to him?
Well, in 2005, there was still widespread skepticism regarding psychopharmacology. The stigma against antidepressants was deeply entrenched, and Cruise was tapping into this pervasive cultural belief that mental health struggles were simply a lack of discipline.
But his comments sparked an absolute firestorm from the medical establishment.
The backlash was immediate and unified. The American Psychiatric Association and the American College of Obstetricians and Gynecologists issued these forceful public condemnations of his assertions. They recognized the real danger of a prominent public figure invalidating a life-threatening medical condition.
It played out on all the daytime talk shows, the covers of tabloids, but the sources indicate this feud was actually a critical catalyst.
Sometimes progress requires a high-profile antagonist. That conflict generated an unprecedented volume of mainstream media coverage. It forced a national conversation.
It gave doctors the mic.
Exactly. It gave medical professionals a massive platform to educate the public on the realities of PPD. And retrospective analyses actually credit that specific cultural flashpoint with significantly reducing the stigma surrounding the illness and normalizing the pursuit of pharmacological treatment.
It is wild to think that a Hollywood clash on a morning show helped legitimize a condition first documented in ancient Greece.
It really is.
But this is exactly where the narrative in the sources takes a hard turn. Because just as the scientific consensus locked in identifying PPD as this strictly biological, hormone-driven illness needing medical intervention, a massive wave of demographic data emerged that completely fractured that neat biomedical model.
Right. This is the turning point where the purely biological framework just fails to explain the reality of the condition.
Okay, I need you to explain this paradox. If we just spent the last 10 minutes establishing that this condition is triggered by a violent 48-hour collapse of placental hormones like estrogen, progesterone, and allopregnanolone, how on earth is it possible that non-birthing fathers are getting it?
It is the ultimate systemic anomaly. Extensive meta-analyses, we're talking about aggregating data from tens of thousands of families, they reveal that between 8 to 10% of new fathers experience clinically significant depression during the postpartum period.
1 in 10 fathers. And clearly, they are not undergoing the sudden detachment of a placenta.
Obviously not. Furthermore, the data demonstrates similarly elevated rates of severe depressive episodes in adoptive parents.
Which conclusively proves that the endocrine crash cannot be the sole driver. I mean, if men and adopted parents are falling victim to this, the internal thermostat dropping to 0 is only a fraction of the story.
Exactly. This realization really forced the psychiatric community to evolve from a strict biomedical approach to a multifactorial model, or a biopsychosocial model.
Okay, break that down for us.
So postpartum depression actually exists at the intersection of three massive converging forces. Yes, the hormonal devastation is a primary factor for the birthing parent. But the second pillar is profound physical trauma and severe chronic sleep deprivation. And the third pillar is a massive psychosocial transition.
The complete annihilation of your previous identity, sudden social isolation, relentless physical demands, and, immense financial and relationship strain.
To really understand the mechanism, just look at what severe sleep deprivation does to the human brain, completely independent of pregnancy.
It's brutal.
It is. Chronic sleep restriction fundamentally alters the hypothalamic pituitary adrenal axis, the HPA axis. It spikes cortisol levels, it disrupts neural plasticity, and it severely impairs the brain's ability to regulate emotion.
Wow.
Yeah. If you combine that neurochemical disruption with a total loss of autonomy and a high-stress caregiving environment that is mechanistically sufficient to trigger a major depressive episode in anyone, regardless of their endocrine baseline.
So the question becomes one of weight. Like, how do we determine if the biological shock or the environmental strain is the primary driver?
We look at the cross-cultural data. I mean, if PPD is purely a biological inevitability dictated by human physiology, we would expect to see relatively uniform prevalence rates across the globe. Human biology does not change across borders.
Right.
But the incidence rates are not uniform.
The sources highlight several societies that have developed deeply ingrained, structured postpartum support rituals.
Yes. The most prominent example studied is the Chinese tradition of zuoyuezi, which translates roughly to sitting the month.
Okay, what does that involve?
It's a highly formalized practice where the new mother is granted a 30-day period of strict confinement, rest, and intensive support. Extended family or hired professionals step in to completely manage the household and infant care. This allows the mother to focus exclusively on physical recovery and feeding.
And epidemiological studies of cultures practicing zuoyuezi and similar traditions show significantly suppressed rates of reported postpartum depressive symptoms.
They do, and this fuels the central scientific debate in perinatal psychiatry. Biological determinism versus psychosocial construction.
Right.
The success of practices like zuoyuezi doesn't invalidate the hormonal crash. I mean, the biology still occurs. But it strongly implies that the level of social scaffolding and cultural expectation dictates whether that biological vulnerability manifests into a diagnosable psychiatric illness or simply remains a difficult temporary adjustment.
It's the difference between jumping out of a second-story window versus jumping out of a second-story window into a stun airbag. I mean, gravity is the undeniable biological reality. You are going to fall. But the psychosocial environment dictates whether you break your legs on the concrete or land safely.
That perfectly encapsulates the multifactorial model. The biology is the fall, the culture is the landing surface.
But this layered complexity makes identifying the illness a diagnostic nightmare for doctors, doesn't it?
Right.
If the symptoms can perfectly mimic hormonal withdrawal, chronic sleep deprivation, or just the overwhelming stress of new parenthood, how does a standard physician screen for it accurately?
Well, the screening apparatus has historically been a massive systemic failure. Interestingly, the medical community actually solved the diagnostic tool problem quite early.
Oh, really?
Yeah, in 1987, a Scottish psychiatrist named John Cox, along with his colleagues, developed the Edinburgh Postnatal Depression Scale, the EPDS.
Okay.
It's a highly effective, simple 10-item self-report questionnaire. It's designed to bypass the physical symptoms of exhaustion and isolate the cognitive markers of depression.
But wait, if they had this highly effective standardized tool available in 1987, why do the sources indicate that the U.S. Preventive Services Task Force didn't officially recommend routine depression screening during and after pregnancy until 2016?
Because medical infrastructure moves at a glacial pace when it comes to maternal health.
Mm.
It took nearly 3 decades for the official U.S. advisory body to mandate that physicians ask new mothers 10 basic questions about their mental state. It is a staggering illustration of how slowly policy catches up to clinical science.
30 years of data showing the efficacy of the EPDS, and it was just ignored by the Primary Preventative Task Force. Is there actually a logical argument against universal screening, or is it purely just bureaucratic inertia?
Actually, there is a vocal, ongoing debate regarding universal screening. Critics do not dispute the validity of the tool itself, they dispute the ethics of screening without an adequate safety net.
Oh, I see.
Yeah, if a physician utilizes the EPDS and identifies a parent with severe PPD, but that patient has no access to affordable psychiatric care, lags paid leave to attend therapy, or, cannot afford the medication, what has the screening actually achieved beyond generating a billing code?
You're just handing them a diagnosis they can't afford to treat.
Precisely. Furthermore, sociologists argue that aggressive universal screening risks medicalizing what are essentially normal human reactions to an unsupportive environment. Are we assigning a psychiatric label to a parent who is exhibiting a perfectly rational response to severe exhaustion, financial panic, and total societal abandonment?
Wow. Which forces us to look at the massive downstream consequences of this condition. If we synthesize everything we've discussed for you, the listener, why is resolving this debate about screening, treatment, and biological versus social causes so incredibly urgent today?
Because the stakes are literally life and death, and they extend far beyond the individual patient. Postpartum depression is not a niche subspecialty of psychiatry. It is a dominant driver of maternal morbidity.
Yeah.
In comprehensive analyses conducted in both the US and the UK, suicide is repeatedly identified as one of the leading causes of maternal death within the first year postpartum.
That's terrifying.
In certain state-level data sets examining late maternal deaths, suicide actually surpasses physical complications like hemorrhage, sepsis, or hypertensive disorders.
That statistic fundamentally shatters the cultural myth that the postpartum period is this inherently joyous, universally blissful phase of life. It is actively lethal for a significant percentage of the population.
It is. And beyond the immediate crisis of maternal mortality, the collateral impact on infant health is profound. The condition severely disrupts early parent-infant bonding, and this is a critical area of focus in child development and attachment theory.
How does that disruption actually alter the infant's development?
Infant neural development relies heavily on serve and return interactions.
Like making eye contact and smiling.
Exactly. The baby coos or smiles, and the parent responds with eye contact and mirrored emotion. A brain suffering from severe depression often exhibits a blunted affect. It struggles to read or respond to those vital social cues.
Right.
And when those interactions are consistently dropped, it alters the infant's stress response systems and foundational cognitive development.
Which means treating the parent's neurochemistry isn't just about maternal health. It is a direct intervention in the infant's long-term cognitive trajectory.
Absolutely. This realization has really pushed PPD out of the isolated realm of psychiatry and into the center of macroeconomic policy. Discussions surrounding the duration of paid family leave, subsidized childcare, and workplace accommodations, they are not just economic debates.
Their healthcare.
They are direct preventative measures against postpartum depression. It was a systemic public health issue masquerading as an individual psychiatric failing.
So to synthesize this entire journey, postpartum depression is a profoundly complex peripartum condition. It's initiated by a dramatic, measurable collapse in neurosteroids like allopregnanolone, but it is ultimately dictated by immense psychosocial and environmental strain.
Right.
It affects roughly 1 in 7 mothers, and surprisingly, 1 in 10 fathers. It is entirely distinct from the transient baby blues and the severe emergency of postpartum psychosis.
And while pharmaceutical advancements have finally delivered targeted biological mechanisms to stabilize the brain, the environmental variables remain entirely unresolved.
Which leaves us with a final concept to consider.
Right.
When you view this condition through the lens of evolutionary biology, it raises a really provocative possibility. Humans evolved as cooperative breeders, relying heavily on tribal networks to raise infants.
Okay.
If the biomedical model cannot fully explain the prevalence of PPD and structured social support dramatically reduces it, perhaps this intense depressive withdrawal isn't merely a disease.
What else would it be?
Perhaps it's an ancient evolutionary distress signal. A biological alarm meant to force the surrounding tribe to intervene and provide resources, a signal that our modern, hyper-individualized society completely ignores. Man. It makes you wonder if the most common complication of modern childbirth is, at its core, simply a physiological reaction to a catastrophic failure of community. Thank you for joining us on this deep dive. Keep questioning the systems around you, and we will catch you next time.